Hello everybody. So today in this module we will be discussing about the OC, otherwise Occipito cervical junction injuries and atlas fractures. Together they can be called as upper cervical spine injuries. But however, upper cervical spine includes occiput, C1 and C2. Here we'll be talking only about OC and atlas fractures. We'll be discussing about C2 fractures in the next module. So before going into the mechanism or presentation of these fractures, we have to know the anatomy of C1 vertebra. So C1 vertebra is otherwise called as Atlas because of the Greek god's name Atlas, who held the world. So similarly, this bone, this C1 vertebra holds our skull in place. That is why it is called as the Atlas. And here you can see the superior articular fossa or facet which articulates with the occipital condyle. This is the anterior arch. This is the posterior arch. This is the anterior tubercle, posterior tubercle, and the next most important structure is the foramen transversarium in the transverse process. This is otherwise called as an atypical cervical vertebra, just like C2, because it is not like a typical cervical vertebra, because there is no body here. It is only anterior and posterior arch and the lateral mass. This particular part of the bone laterally, which is a mass of bone, is called as the lateral mass, and then comes the foramen transversarium in the transverse process. Regarding the anatomy of occipito-cervical region, the most important thing is the ligaments rather than the bone. So we have to understand the ligamentous anatomy very clearly here, because they are responsible for the ultimate stability of the occipito-cervical junction. So here you are seeing the axial view at the level of C1. You can see the facet joints. You can see the odontoid peg here and anterior tubercle. And these are the anterior and posterior articular capsules which keeps the odontoid peg in place. But the most important ligament which we are bothered about is the transverse ligament, which gets attached to the lateral mass of C1 on either sides, and that is the ligament which holds the odontoid in place, just like this. So because of this transverse ligament, the odontoid will not move anteriorly or posteriorly. That is very, very important. This is the other view which shows clearly the transverse ligament, and these are the alar ligaments and the apical ligament which arises from the odontoid. Odontoid is nothing but a continuation of C2 body. Now coming to the sagittal view, here you can see the odontoid here. This is the C2 body, this is the odontoid, spinous process of C2. This is C1 posterior arch, C1 anterior arch. As I said, the odontoid is just behind the anterior arch of C1, and this is the anterior atlanto-occipital membrane, which is nothing but a continuation of the ALL or the anterior longitudinal ligament. And here is the posterior atlanto-occipital membrane. So these two membranes are very, very important in holding the occipital condyle to the atlas. So these are the main restraint, and they prevent the instability at this junction. So these two membranes are very, very important. Apart from that, there are certain ligaments which connects various bony structures to the odontoid. One of these most important structure is the cruciate ligament. So as you can see, this is the transverse ligament, and these fibers, superior and inferior fibers, and this, the entire thing forms a plus shape. That is why it is called as the cruciate ligament. Then from the tip of odontoid, you have the apical ligament which goes and gets attached to the top. Similarly, there are ligaments which are called as the alar ligaments, which goes from the odontoid and gets attached to the side. So the entire thing, along with the tectorial membrane here, they form the major stabilizing element of the upper cervical spine, including the posterior atlanto-occipital membrane, which we discussed here. So this complex anatomy or complex ligamentous structures are responsible for holding the C1, C2 and occiput in its place. Now, occipito-cervical dissociation, of the three topics which I am going to discuss here, occipito-cervical dissociation or dislocation and occipital condyle injuries are very, very rare. Even if you are an exclusively practicing spine surgeon, you may see hardly 3 to 5 patients with these conditions in your entire lifetime. So it's not very common. It is relatively common in children because of the laxity of the ligamentous structures, along with the presence of a relatively large head and higher effective fulcrum in the pediatric cervical spine. Most of these injuries or the dislocation will result in sudden death at the place where they sustain the injury because of injury to the brainstem. If the patient survives, they can have vertebral artery insufficiency, cranial nerve injuries or spinal cord injury. Now, it is basically because of complete or near complete disruption of the ligamentous structures, which we discussed in detail now. There could be extreme forces in hyperextension or hyperflexion and lateral flexion, or it could be a combination of all these forces. And the hyperextension can result in rupture of the tectorial membrane, or incompetence of the alar membranes, ligaments and tectorial membrane allows for the anterior dislocation of the cranium. The entire cranium passes anteriorly with respect to the upper cervical or C1. Now, this is one of the important classification systems for craniocervical dislocation. It is called as the Harbor-View classification system. According to this, stage 1 is whenever there is MRI evidence of injury to these ligamentous stabilizers with distraction of less than or equal to 2 mm on provocative traction radiography. This is one of the disadvantages of this classification. You are provoking and you are giving traction and taking a radiograph, which is quite dangerous. Stage 2 is there is MRI evidence of injury to these and distraction of greater than 2 mm is seen, and stage 3 is craniocervical malalignment of greater than 2 mm on static radiography without giving any traction forces. If there is greater than 2 mm of displacement or dislocation, it is stage 3. Now, coming to the diagnosis, these two parameters in the x-rays are very important. First one is the BAI. It is called as the basion axis interval. So this point of the occiput, the anterior part, is called as the basion, and this point is called as the opistheon of the occiput. So here basion axis interval, as the name indicates, you draw a line along the posterior aspect of the axis. The distance between the basion and the axis is called basion axis interval. Whenever there is an increase in the distance of basion axis interval of greater than 12 mm anteriorly or greater than 4 mm posteriorly, then it is something wrong. The next is the basion dens interval. It is the distance between the basion and the tip of the dens, that is the odontoid process. Odontoid process is otherwise called as dens. So whenever there is an increase in the basion dens interval, again it means there is some dislocation or instability. The normal basion dens interval is about 10 mm. So the next most important thing is the Powers ratio. The Powers ratio is nothing but the ratio between the opistheon and the posterior aspect of anterior arch of atlas divided by the basion and the anterior aspect of the posterior arch of atlas. Normally the ratio should be less than 1. If it is greater than 1, it is abnormal. So these are the important radiographic parameters. But now after the advent of CT scan, MRI scan, it is quite easily visible. But even then, these parameters are very important to know whether there is an instability at this region or not. Because CT scan and MRI are usually static images.